In this video, we'll discuss about the multinodular goiter. So, we will discuss it in the form of first we'll discuss about the definition, then we will discuss about the pathogenesis, followed by etiology is done. So, epidemiology, clinical presentation, investigation and diagnosis, management. So first of all, coming on to the definition. Now it is basically defined as the end stage result of diffuse hyperplastic goiter. Now let's discuss about the etiopathogenesis. Now you must remember when I talked about the classification. So I talked about two or three things: colloidal goiter, iodine deficiency goiter, and pregnancy goiter. So we'll discuss them again over here. So the first one being what happens is there is increase in the metabolic demands due to which there is an excessive enlargement of the thyroid gland. This basically happens in multinodular goiter in a nutshell. But now I'll discuss according to the needs that are causing that are increasing the demand. So first of all, it is very common during the pregnancy, puberty. These are basically physiological conditions. Now they are leading to an increase in the, I hope it's visible, increase in the metabolic demands, due to which there is TSH production increased, due to which thyroid gland is increased in size. So it's basically diffuse hypertrophy and hyperplasia. Alright, now it may disappear when thyroxine is given. So now we'll talk about another form, which is the iodine deficiency goiter. Now you must mention the daily requirement of iodine. So it usually is around 100 to 125 micrograms. Now it is usually seen in hilly areas or the mountain areas or the low-lying areas. Why is it so? Because they do not have enough of iodine content. So basically we preferably tell them to use iodized salts. Alright, then there is colloid goiter when basically there is deficiency of iodine for a longer period of time, then we call it colloid goiter. So deficiency for a longer period of time. Alright, now after this I'll discuss the pathogenesis. Now there are certain goitrogens. Alright, so goitrogens which basically are cabbage drugs like para-aminosalicylic acid, sulfonamides. Now what they do is they cause the prevention of I negative to iodine molecule. Now let's talk about it. First of all, we have low levels of T3 and T4. Now what all will cause low levels? So first is the iodine deficiency, pregnancy, puberty, some genetic defect, goitrogens. Now this will lead to a feedback mechanism, TSH secretion increased. Now due to this TSH secretion increased, there is a mixed pattern. On one place there is going to be diffuse hyperplasia, and on the other side it is going to be necrosed follicles, thus leading to multinodular goiter. Now it can further lead to malignancy or toxic multinodular goiter after some years. So yes, this is the etiopathogenesis. Now let's talk about the clinical epidemiology first. So in epidemiology, we know that it occurs usually in the age of 20 to 40 years, and is more common in females in a ratio of 10 is to 1. Okay, then it usually site is it usually occurs at the junction of isthmus with one lobe. All right. Now in the clinical features, what we see is it usually is a swelling. So it is a long duration swelling in front of neck. You can write about dysphagia, tracheomalacia. Also the gland, it is enlarged, nodular. Then the soft areas are necrosed areas, and the hard areas are calcified areas. Then the complications. Now in complications of multinodular goiter, in a prolonged one, you will see calcification. Then there can be hemorrhage. Also there is going to be, in 20 to 30% patients, there is CVS involvement. Then there can be development of toxic multinodular goiter, which is the Plummer's disease. Now let's talk about the investigation and diagnosis. Now for investigation, we do an ultrasound, the MRI, CT. Then there is one test which is the isotope scanning test. Now in this, basically two outcomes are there usually. One is the cold nodule, one is the warm, and one is hot. Now in hot, what happens is, suppose this is our thyroid and this takes up the stain, the radioactive. So this doesn't. So like the whole takes, all right, and in this doesn't take. So what you usually see is that the warm nodule, it is suggestive that all cells are equally stimulated and active. So this you will see in multinodular goiter. In hot nodule, what you see that only the nodule, it takes the isotope, but the gland does not take. So it is basically the nodule part is active. So it is a solitary toxic nodule, and the normal tissue, it is suppressed. Now, in cold nodule, what we see, neither the nodule nor the gland, none of them take the isotope. So, it is basically chance that it is 10% malignant. All right. Then what we do is routine complete blood culture, also X-ray of the chest. Now in X-ray of chest, you must remember two three things that I want you to remember. So first of all, why do we do it? Just remember renal cell carcinoma, okay? But not through the name, but by the mnemonic. So by R, I want you to remember to rule out retrosternal extension. By C, I want you to remember calcification. And by another C, I want you to remember compression of trachea. Alright. Now, in ultrasound also, we just come to know that whether it is single, multinodular. Alright. Then we can also do fine needle aspiration cytology. Then let's talk about the management part. Now in the management part, it is very important first to act as prevention. Now the we know that prevention is better than cure. So in prevention, in case of puberty goiter in iodine, what we give is 0.0 to 2 milligrams of thyroxine. Now, basically, iodine deficiency goiter, the people residing in such areas should have iodized salt, seafood, milk, egg, and they must avoid goitrogens. All right, so goitrogens such as cabbage and drugs like PAS, right, phenytoin, and so on. Then coming on to, if it is not being prevented and it has already occurred, then what you will do? We will resort to the surgical treatment. So in surgical also, you just need to remember very easy things. One is total and one is subtotal. Okay, now in total, what you do is you take out the entire thyroid gland, but here what you do is you actually leave something which is just the size of a plum or finger, basically in the tracheoesophageal groove. Why do you do so? Because you want to protect the RLN paralysis, and you want to also protect the parathyroid glands that are usually situated over here. Okay, so this is it. Also, there is one more thing, that the patient should also be treated with thyroxine during all this things, because there can be suppression. All right, so this basically you can write it in a better way. Yeah, so this basically completes the multinodular goiter. I hope I made it easier for you to understand. Thanks for watching.